Good evening, ladies and gentlemen, and all those who are in the West, good morning. Welcome to the 31st Journal Club of Indian Myeloma Academic Group. And today we are going to discuss a clinically very relevant topic, that is the role of sustained MRD negativity for 3 years to modify the therapeutic decisions. So for this, we are very happy to have from the MGM Cancer Institute, Dr. Gopinathan M, who will be presenting the journal and he would be dissecting the article. To discuss from the national faculty, we have Dr. Sadashivudu from Nizam Institute of Medical Sciences, Hyderabad, and Sir would be giving the comments with reference to the low middle income countries and in Indian parlance. And we have none other than the first author of this article, Dr. Evangelos Terpos from University of Athens, School of Medicine, Greece, and he is also a member of European Society ESM guidelines. So thank you, sir, for taking your time out and coming to participate and discuss this article. As a first author, you being here is a real great privilege for the Indian Myeloma Academic Group. So with this, I would like to hand over the stage to the moderator for the day, Dr. Sadashivudu sir, to take on the discussion, please.
Yeah, good evening, ladies and gentlemen. I'm very honored to just moderate this session. I think all of us, we know that when this, even after transplantation, when to stop this maintenance therapy is a big topic nowadays. I think, as you know, that one nowadays, whether you have to be the 2 years or 3 years or 5 years, with the recent advances in this MRD and imaging, I think can we stop? I think none of other than Dr. Terpos is the first author of this article. He's here today. I think we are solve the problem by listening to this presenter, Dr. Gopinathan M. He's from MGM Healthcare at Cancer Institute. After this, his presentation, we would like to have the detailed discussion. So, how to stop, when to stop, whether we have to stop it or not. I think ultimately we'll present this journal club and discussion. Thank you once again for all these presenters and Dr. Terpos, Dr. Pankaj Malhotra, other people who are joining here. So over to you, Dr. Gopinathan, now.
Good evening, everyone. At the outset, I would like to thank the organizing committee of Image Working Group for inviting me to present the journal club for today's evening, as well as to keep us updated about the progress in the field of multiple myeloma. So the journal club for today's discussion is whether sustained bone marrow and imaging MRD negativity for 3 years can it drive discontinuation of maintenance post-autologous stem cell transplant in myeloma. The corresponding author is none other than Professor Evangelos Terpos, who is a renowned figure in the field of multiple myeloma. So we all know that there is a strong beneficial role of continuing maintenance post-autologous stem cell transplant in multiple myeloma. And before we get there, we need to know that the disease control in myeloma needs to be always multifaceted, which is using a combination of electrophoresis, MRD assessment by flow cytometry, and imaging negativity. Now, we all know that the bone marrow MRD assessment in myeloma is getting standardized across Indian centers, and we know that the deeper the remission, better is the progression-free survival. We already have an inspiration from chronic myeloid leukemia, where we know that deeper the remission, better is the disease control, and we can go in for something called as TFR, treatment-free remission. The same is inspired here, where patients of multiple myeloma, once they attain deeper remission, whether they are eligible to do lenalidomide maintenance discontinuation or not. So the research question now here is, now that we have a potent induction agents, which is either a triplet or quadruplet, and followed by a safer consolidative autologous stem cell transplant under tailored maintenance, which is single or double based on your cytogenetic risk, should the initial strategy of continuing maintenance until progression, can it be re-explored in the current era? Because we now have a deeper MRD techniques, and whether continuing maintenance until progression, will it impact quality of life rather than actually giving a benefit? And if at all we discontinue, whether it is safe to discontinue. So these were the 3 main questions that we are going to address for today. So this is the traditional response assessment criteria that we follow for all of our myeloma patients, but I'm not going to go into the details of it. Whereas this table, I want all of you to have a look at, which is flow MRD negative, where you prove absence of clonal plasma cells by next generation flow using a standard Euroflow operating guidelines, and which has got a sensitivity of 10 to the power of 5 or even higher. Whereas when you prove it by an NGS, that is next generation sequencing, which again has got a sensitivity of 10 to the power of 5 or even higher, it is called sequencing MRD negative. When you prove both MRD and imaging negativity, it is called as imaging plus MRD negative disease. And here it's an important thing that you note for this current very relevant to this particular journal club discussion is sustained MRD negativity, which is you prove MRD negativity in the marrow by either NG next generation flow or a next generation sequencing and imaging, and it should be at least 1 year apart, right? So that is sustained MRD. Now you can actually extrapolate this particular terminology for like 2 years, 3 years, and so on, saying like sustained MRD negativity at 2 years, sustained MRD negativity 3 years, 5 years, and so on. So now the main objective of today's topic is after attaining sustained MRD negativity, which I mean both in bone marrow flow as well as in imaging for 3 years, whether it is safe to discontinue lenalidomide maintenance, and if at all we discontinue, which subset of patients it can be safely advocated. For this, the study population was taken from the author's own center, which is Department of Clinical Therapeutics, National and Kapodistrian University of Athens, Greece. And after getting approval from the Institutional Research Board, the study was conducted for a duration of 5 years, from 2016 to 2021. They did have a sample size of 48, which was calculated from the Sentinel paper by Rosinar et al., where the author tried to taper the maintenance to a doublet based on the MRD negativity. So they did inspire from the same study, which had a 3-year TFS of 75%, and setting a non-inferiority threshold to it to a tune of 58%, and using 80% power and 0.05% alpha. The sample size that they arrived was 48. So for this particular study, for the current study, they did assess 194 patients for eligibility, of which 52 qualified. Now, getting on to the eligibility criteria for current study, they did enroll patients more than 18 years, newly diagnosed multiple myeloma. They should have undergone 4 to 6 cycles of triplet or a quadruplet induction, followed by an autologous stem cell transplant. And 2 cycles or triplet consolidation was allowed only if the patient has received 4 cycles in the initial induction. So for a patient altogether, only 6 cycles of triplet or quadruplet therapy is allowed. And once after all of this, they enter into maintenance after attaining a very good partial response, VGPR, with a dose of lenalidomide being either 10 mg or 5 mg according to their best tolerance. But it is very interesting to note that before entering maintenance, they need not be a strict criteria to have MRD negative. So even here, if you note that of this patient before entering into maintenance, almost 44 were MRD negative, whereas 8 were MRD positive. But eventually, after entering into maintenance, almost in a period of 1 year time, all these patients became MRD negative. Now, once after entering into maintenance, these patients are followed with serial bone marrow examinations with MRD and imaging at least once per year for 3 continuous years. So once if they have a sustained bone marrow and imaging MRD negative for 3 continuous years, they are eligible to discontinue lenalidomide maintenance from 3rd year onwards. So once after discontinuing maintenance, how did they follow? They did follow with CBC, creatinine, protein electrophoresis every 3 monthly. MRD was done at the baseline during study entry and every 6 monthly according to the same IMWG working group criteria, and an annual PET CT. So whenever these patients turned MRD positive through the serial examination, they were restarted with lenalidomide. Whereas if they had a frank biochemical or a clinical progression, then they are started with second line induction agents and chemotherapy. So MRD, we talk here by 2 different modalities, like one is by flow MRD and second is by imaging MRD. So the flow MRD technique that was used here is through the standard Euroflow guidelines, which has got a sensitivity of 2 into 10 to the power of 6 through NGF, with the traditional antigens used being CD19, 27, 38, 45, 56, 138, and the surface panel being 81 and 117, and intracytoplasmic panel being cytoplasmic IgG kappa and lambda. And again here, to prove imaging MRD negativity, the uptake should be lesser than your bone marrow and liver, right? So this is how a traditional difference is drawn between next generation flow and next generation sequencing, where they have the traditional sensitivity reported here was 10 to the power of -5, whereas in the study, the sensitivity of 2 into 10 to the power of -6, where we require a more stringent sample collection and a fresh sample. Usually it should not be hemodiluted, and the turnaround time is usually 2 days if you have in-house collection and 4 days if you have an outsourced lab. So this is how traditional myeloma MRD reporting is done in our country at this point of time, where you can see the pathologist writes what point of time the sample is taken, whether the sample is hemodiluted or not, okay, and whether the events acquired are adequate or not. And finally, after going through these many antigens, the hematopathologist reports whether it is positive or negative. So what are the study endpoints? So the study endpoints were, first is the rate of MRD conversion, that is rate of patients turning MRD positivity, and treatment-free survival when, once after they discontinue lenalidomide. So this was a pro-primary endpoint. Secondary endpoints are rate of progression after lenalidomide discontinuation, rate of progression despite re-administration of lenalidomide, progression-free survival, overall survival, and adverse events resolution post lenalidomide discontinuation. This is more often taken as a quality of life measure, as a secondary endpoint. So this image tells you to put things into more clarity. So this is the time point where the patients were diagnosed. That is at the primary diagnosis of multiple myeloma. They undergo induction, transplant, consolidation plus or minus, and then maintenance. And in maintenance, 3 successive years they should be MRD negative, which is both by flow and imaging. And once they have that sustained MRD negativity, then they are eligible to have the trial entry. Okay, so the trial entry is only possible when they have sustained 3-year MRD negativity both by flow and imaging. So they are discontinued lenalidomide maintenance at this time point and they are serially followed. So once they get MRD positive through bone marrow flow examination, then they are restarted with lenalidomide. So from after the trial entry, bone marrow is done every 6 monthly, whereas PET is done annually, right? So this time point from the trial entry to the resurgence of MRD positivity is called as treatment-free survival, whereas landmark progression-free survival is nothing but, from the trial entry till you have a frank biochemical or a clinical progression. PFS and OS, same like any other myeloma trial definitions. From the diagnosis till you have a frank clinical or biochemical progression, or you have death due to disease per se or death due to any other cause or loss to follow-up. So with this, after understanding this, the total number of patients taken into study were 52. Age group is typical how a myeloma cohort is distributed, like 56.5, as young as 40 to as high as 66. Equal gender distribution. As like any other myeloma cohort of patients, 78% of these patients had bone disease at baseline, 23% had anemia at baseline, 13% had hypercalcemia and high LDH, and 10% did have renal impairment at baseline. So this table, I want all of you to have a look at the proportion of high-risk cytogenetic patients involved in the current study. We can see here high-risk cytogenetic abnormality more than 1, almost 21.2%. Whereas if you put them across through ISS 3, it was 13.5, RISS 3, it was 5.8, R2 ISS 3, it was 21.2, and R2 ISS 4 was 1.9%. So it kind of looks lesser, probably because the total number of samples that were taken for this particular observational study itself was 52. Again, this is the traditional distribution of myeloma patients according to the immunophenotype, which is commonly IgG followed by IgA, light chain, and only one patient had a non-secretory disease. So the type of induction regimens used in this particular study was again, most commonly VRD followed by VCD, VTD, and DARA VRD. Very important to note that only one patient had received a quadruplet induction. So most of the other patients had received only a triplet induction. So traditionally, how we all do in our own century and centers, and you can see that 46%, that is 24% of the 24 patients had received consolidation, either post transplant. But it's very important to keep that the total number of triplets that were allowed for any patient here is 6, either 4 induction or 2 consolidation, or 6 induction and then transplant and maintenance. So with this, we go to the results of the study. So we all know that they should have 3-year sustained MRD negativity. So during that time, obviously they'll be exposed to lenalidomide. So the median exposure to lenalidomide was 37.5, the lowest being 36 months, which is 3 years, and the highest being 62 months. And the median follow-up from the study initiation was 3 years. That is after the trial point where we have MRD negativity, and we have a wide range from 0.58 to 4.7 years. Whereas if you take the median follow-up from diagnosis is quite huge, which is from 7.26 years, the range from 4.5 to 9.8 years. So now what was our primary endpoint, which is once after discontinuing lenalidomide maintenance, how many are turning MRD positive and what time frame, right? So that was our primary endpoint. So here you can see almost 12 patients did turn MRD positive at a median of 27.5 months. So if you put breakdown according to the months or years, at the end of 1 year, 4 patients did turn MRD positive. At the end of 2 years, 7 patients at the end of 3 years, 12 patients at the end of 4 years, it again constantly remains at 12 patients. So majority of them turn MRD positive after a period of 2 years time. And it is very interesting to note that of the 12 patients who turned MRD positive, 6 had a high-risk cytogenetic abnormality and none had a frank disease progression before getting MRD positivity, before turning MRD positive. So which tells you that MRD is a much earlier predictor, right? Again, so what are the other survival endpoints? The 3-year treatment-free survival, which was 75.8%. If you break down upon years, TFS at 1 year, 2 year, and 3 year were 93.9, 91.6, and 75.8%. The overall median progression-free survival for the entire cohort wasn't reached, whereas if you take at 7-year progression-free survival, it was 90.2%, which is quite good. And the landmark progression-free survival, if you take it 1 year, 2 year, and 3 year, it was 96, 96, and 92.9%. So this is the treatment-free survival. If you can see here, when these patients turn MRD positive, that is at a median of 27.5 months. You can see a dip after 2 years. So this is the typical TFS which I had discussed after the trial entry. Whereas if you see the progression-free survival, it is almost flat till 7 years and slightly it starts, getting down after that. Right? So now what happened to these patients who turned MRD positive? So we are putting them into two cohorts. So one of which 4 had a frank progression, of which 3 had biochemical progression and 1 had a frank clinical progression. For the for all of these patients received subsequently an anti-CD38 based triplet induction, of which 3 were in remission and 1 patient who had a frank clinical progression is now on third-line chemotherapy. The other 8 patients who had MRD positivity, 1 had become MRD negative only in 6 months time frame, and the 7 patients who had just MRD positivity were continuing only on lenalidomide maintenance. Now, once after an initiation of lenalidomide, the median follow-up time from the reinitiation of lenalidomide was 11.5 months, in which I had a wide range from 0.5 to 38 months, and no MRD positive patients had disease on imaging. So that is again one important point to be noted. So again, resolution of adverse events, which was taken as a quality of life measure here. So it's very the more than grade 1 adverse event that was noted during the time of lenalidomide maintenance was 52%, and no patient had discontinued the drug due to toxicity. That is when they are taking the maintenance regimen, none had discontinued due to toxicity. But after discontinuation, 62% of the patients who reported diarrhea, the symptoms completely resolved. And those who had skin rashes, almost 3, they had also completely gone away once after discontinuing maintenance. So this is more to do with the quality of life measure. Again, when they tried to test PFS and TFS for this variable covariates, for all this covariates, whether it is making any difference like age, gender, higher R2-ASS, induction therapy or consolidation therapy, they could not find any, decipher any significant difference between your progression-free survival and your treatment-free survival. So now what we know of MRD already, MRD negativity in myeloma, despite doing an ASCT above, before maintenance, it has got a better progression-free survival. So whether you do ASCT or not, but MRD negativity before maintenance, these patients have got a better progression-free survival. And MRD negativity nullifies high-risk cytogenetics, right? So despite being high-risk cytogenetics at the baseline, if you have MRD negativity, these patients did better. And durability of MRD negativity, like it has got a better progression-free survival. That is in accordance with the previous trials, which is by Pollux and Castor, where they did prove 2-year durable MRD negativity. These patients again did better. And loss of MRD negativity is worse than persistent MRD positivity, right? And MRD positivity always precedes biochemical relapse by 4 months and clinical relapse by 10 months. So which is again we saw in the current study as well. And this is very important to note here. Now, in clinical practice, we always find some kind of discrepancy between bone marrow MRD negativity and imaging positivity. And this happens more with the relapsed disease, like where you can see as numbers as high as 50% versus 12% in the upfront, that is with the primary line of therapy, first line of therapy. So again, in the historical trials which reported the same discrepancy, IFM 2009 trial had reported almost 26% discrepancy, and Cassiopeia trial almost 10.5%, right? So in our current study, at most 19 of the 52 had a baseline PET-CT scan, means at the diagnosis. During the time of entry into maintenance, at least one patient had a discrepancy, who was MRD negative but imaging positive. But before entry into the trial, all had MRD, all had imaging negativity. During reconversion to MRD positivity, that is after the trial entry, when they converted into MRD positive, no new lesions on imaging were found, which again tells you, it precedes the clinical and the biochemical relapse by so on. Now, what this study adds, sustained MRD negativity strongly correlates with progression-free survival. And it is a better marker that when you do a sustained MRD negativity for 3 years, it is a better marker when compared to use of 2 MRD negative time points, which is described in the historical trial cohorts. And it is also proved that late MRD converters had a better PFS than early, but the statistical difference was not attained in the current study, probably because the total sample size itself was, the who converted MRD positive was very small, and the time duration follow-up is very short, right? And MRD persistence outcomes were bad. And of the 4 who had a frank progression, in the early years of discontinuation of maintenance, 2 had high-risk cytogenetic component. So this is a very important point to note down. Okay, so the proportion of patients who progressing, these people had a high-risk cytogenetics. And even after turning MRD positive, once you reintroduce lenalidomide maintenance, the 3-year PFS is as impressive as 80%, right? So it's not a bad thing to be looked upon. And sustained MRD negativity with the first line regimen, they have got an impressive PFS and impressive overall survival benefit, right? So what are the limitations for the current study? The follow-up duration from the diagnosis was quite huge, but the follow-up duration after reinstillation of lenalidomide was quite short. And the high-risk subgroup, the proportion of people involved in the high-risk subgroup analysis is quite small, probably because the entire sample size is only 52. And we have to convince the patients for getting a marrow examination every 6 monthly. That is quite difficult in our clinics, to do. And again, flow standardization across Indian centers is happening. And when we get patients from multiple centers outside, all may not have a baseline PET-CT. So if we have a baseline PET-CT, things to compare would be much more easier. And this also being a single center study and no comparator arm, these were some of the limitations to say for this particular study. But what are the important takeaways? If we are able to do a standard triplet induction as we do across in our centers and an autologous stem cell transplant at 200 milligram per meter square, right, of melphalan, if you have sustained MRD negativity for 3 years, that is deep MRD negativity, then we can safely, discontinue lenalidomide because the rates of reconversion to MRD positivity is quite low. And applying the same to high-risk subgroups should be taken with a pinch of salt. And all facets of MRD positivity need to be taken into account, be it electrophoresis, imaging, plus flow MRD. And in the future, we will have circulating plasma cell, which can be detected through peripheral blood flow cytometry as one of the measure to detect MRD. So that needs to be the future forecast. And taking this particular study results, whether we can do tailored maintenance in future is the open question, and it is for open house discussion. So with this, I'd like to thank for the opportunity and like to stop sharing.
Thank you, Dr. Gopinath. The wonderful discussion. I think you have presented very nicely the important points as well as the limitations of the study also. I think really great. I think now we have the purpose, Doctor. So he can have his comments, then anybody can ask some questions and we can answer. Over to you, sir, now.
First of all, thank you for the kind invitation. I would like to thank Dr. Gopinathan for an excellent presentation of my study. Thank you so much. I think this is an interesting study. We started that 7 years before, and at that time we have not any idea if we can stop treatment of maintenance based on MRD. But we thought that patients with very low tumor load, like MRD at the 10 to the -5, which is sustained for more than 3 or 5 years. We didn't know exactly. So we started this study with MRD negativity for 3 years, but we had in our mind if we had to go for MRD sustained negativity for 5 years. But then we've seen the results of the MRC11 study that they have shown that after 3 years of sustained MRD negativity, if the comparison between lenalidomide maintenance and observation was totally similar. For this reason, we decided to continue with the 3-year MRD, sustained MRD negativity. I think that this study gives you 2 important information. The first is that for the standard risk patients, it seems very logical to stop maintenance after 3 years of both marrow and imaging MRD negativity. And the second is that even at the time of MRD positivity, from MRD negativity, if you restart lenalidomide, it seems that there is no value for that. The patients will continue to go from MRD positivity at the 10 to the minus 4 to 10 to the minus 3, and then they will have biochemical progression. Another important issue is that we have not had any patient who went directly to biochemical progression or clinical progression before going from MRD positivity while the patient was in MRD negativity. So I think that all these 3 important issues have been discussed in this paper, and definitely a big study, that randomized study that will have as a major point to stop treatment is needed. In the Perseus study, which is a study that is using double maintenance after Dara-VRD induction, autologous transplant, Dara-VRD consolidation, and Dara-R maintenance, if the patient has 2 years of MRD sustained negativity, they stop, but only Dara. They continue to receive lenalidomide. So we need studies that the patients will stop maintenance. I think that this is the most important thing in order to our study to have a bigger influence in the community.
So the question here is one question: did anybody receive doublet maintenance therapy?
No, we have not had any patient who had double maintenance, only lenalidomide maintenance, because this was the approved indication in our country. And unfortunately, this study has not been supported by any pharma company, so we cannot do any difference from what it has been licensed at that time.
Very good, sir. And one more thing is, again, this lenalidomide dosage is a 10 mg, 21 days or continuous? Some people, they'll use 21 out of 28 days. So
lenalidomide was given continuously every day. The vast majority of the patients received 10 milligram. Only if they had any problem of side effects with the 10 milligram received 5 milligram. But otherwise, they received every day.
Thank you, sir. So,
can I ask a question?
yes, sir.
So, Dr. Terpos, why did you choose 3 years as the cutoff sustained MRD? Why not 2? Why not 1.5? So, what was the basis for using taking a cutoff of 3 years? That's my first query. And second query, did you correlate this with any of the genetic information of the patient? What I mean to say is this results, are these results uniform across different RISS stagings or the different genetic baseline genetic evaluation of the patient?
Thank you for these questions. As Dr. Gopinathan presented, patients with high-risk disease had a higher probability of going from MRD negativity to MRD positivity, and even to biochemical or clinical results. Almost 6 out of the 11 patients who were high-risk cytogenetics, they went from MRD negativity to MRD positivity, and 2 of them had biochemical relapse. So the high-risk cytogenetic, I think, is an important factor. And with the data that I have to date, I will not stop maintenance in high-risk patients. Only I would think to stop maintenance based on my data for the standard risk patients after 3-year sustained MRD negativity. Why 3 years? As I previously mentioned, we had discussed the 3 or 5, not the 2 years, because we knew the data from the English group, which had already published that 2-year sustained MRD negativity, the lenalidomide maintenance was better than observation. So we knew that 2 years is not enough when you talk about lenalidomide as monotherapy maintenance. So our question would be 3 or 5. So we said that we will start with the 3 years, and if we see very bad results, that we have high rates of conversion, we go for the 5 years. We would make an amendment in our inclusion criteria. But then the English study also suggested that after 3-year sustained MRD negativity, I talk about the MRC11 study, if you compare lenalidomide maintenance versus observation, there was no difference. And with that result that was presented by Christine Pauling in the ASH 2022 meeting, we felt more relaxed and more safe that we are doing the correct thing.
Thank you, sir.
Questions. One more question. Does the MRD negativities depend on quadruple or triplet regimen?
Sorry that I didn't hear the question very well.
This
Also...
MRD negativity and the
Yeah.
response, whether it is related to the quadruple therapy or triplet therapy, DARA-based or non-DARA-based, any subset or something, any idea?
As I mentioned previously, this study is not a pharma-sponsored study, so we had to support this study by ourselves. At that time that the study started, which was 2016 and 2017, in order to include all patients who receive induction, the induction regimen in my country included mainly VCD and after a while VRD. That's why you used mainly triplets, these 2 triplets in the vast majority of the patients. With the quadruplets now, we are going to have a bigger proportions of patients who will have 3-year sustained MRD negativity. If you can see the patient characteristics that Dr. Gopinathan presented, these patients were only the 26% of the total population that were screened. I mean that the total population who received induction and transplant, because with VCD and VRD, the proportion of patients who can manage to have sustained MRD negativity for 3 years is less than 30%. So in our series, it was between 26 and 27%.
Yeah. Thank you for your wonderful discussion, sir. I think to my understanding, after reading and going through the journal, so MRD negativity is most important predicting factor to stop the lenalidomide maintenance. Is it right, sir? Sustenance of the MRD negativity.
Sir, Sadashiva, sir, we are not able to hear you clearly. Can you just slightly say it loudly, sir?
The sustenance of the MRD, irrespective of the triplet or quadruple dose, is important. Is it right? Sustenance of the MRD.
Okay. So basically what he is trying to ask you is, irrespective of what the number of drugs that we are using, if a person is MRD, he's having a sustained MRD negativity. So is that sufficient to stop the drugs, irrespective of the number of agents used?
Yeah. I mean, this study was for MRD negativity patients, irrespective of the drugs that we are using in order to achieve the MRD negativity for sustained for 3 years. And all the studies, the majority of the studies have shown that irrespective of the drugs that you are using in order to have MRD negativity, the prognostic value of MRD negativity seems to be similar. with, of course, some exceptions for the high-risk patients.
May I ask a question? My voice is very bad. This is General Nair, but I'm very tempted to still ask a question. In the high-risk patients, since we know them upfront who are the risk stratification, you think there is a scope in further studies? We talked about the consolidation, which is itself a little controversial, how much and how long should we give it? You did say that 4 + 2, 6, not to exceed 6, pre and post transplant included. So in the high-risk group, is there a scope for giving them a structured consolidation, which is a little bit, irrespective of how many cycles he's got pre-HCT, to still give him, irrespective of that, 2 cycles in the high-risk group?
So for the high-risk group, we definitely want to achieve an MRD negativity. So you have to use the best options that you have. For example, in the German study that was just published in Journal of Clinical Oncology using isatuximab VRT as a quadruplet induction, and then 4 cycles, and then the autologous transplant, if the patient of high risk has not achieved at least complete response after the transplant, they offered a second transplant. So this is one thing that you can do for the high-risk patients. And in the new European Hematology Association guidelines that have just been accepted for publication in Nature Reviews in Clinical Oncology, that I'm the corresponding author, we have included that in the guideline, that for the high-risk patients, you can use either a second transplant or 2 more cycles of consolidation in an attempt to achieve MRD negativity, which is something that we want. I think that it is a must for the MRD negative patients to achieve, so for the high-risk patients to achieve an MRD negativity. And I will give you one more information about that. When we have started to have MRD negativity in my center, we did the study we did the evaluation for patients who were in sustained complete response for 5 years. So we had approximately 60 patients who were in sustained complete response for 5 years. And we did the MRD testing in these patients. And we've seen that 40% of these patients, 40%, were MRD positive. But none of these patients had high-risk cytogenetics.
Thank you.
So the high-risk cytogenetics have to be treated till achieving MRD negativity.
Thank you.
Sir, I have one more query to ask. In your study, you have shown that the imaging predicted positivity almost 6 months earlier than the flow. Am I right? When you do imaging MRD and when you do flow MRD, you found imaging MRD was better and earlier predictor when compared to the next generation flow.
No, what we did in our studies, after achieving MRD negativity in the bone marrow, we had every 6 months the bone marrow evaluation, but every year the PET-CT evaluation because of the radiation, mainly because our radiation ethical committee did not allow for an MRD negative patients to have the PET-CT more often, only if there were signs of progression.
But the patients who became further positive, they became positive by PET-CT or the imaging earlier than the flow.
In the bone marrow, by flow.
Okay. So
the PET-CT at the respective time was negative.
Okay. So if we have to choose between the two, as per your study in resource constraint study settings, which one would you prefer, the flow or the imaging? If I have to choose one.
If I choose one, the flow, the bone marrow. Just to let you know that from 100 patients who are MRD negative by bone marrow flow, the positivity in the PET scan is only 10 to 15%.
Thank you, sir. Sir, there was one question from Dr. Pankaj.
Sorry, one
Sir,
more information.
please, sir.
One more information. For the sustained MRD negativity in the bone marrow for 2 or 3 years, in our center, we had never had PET-CT positive patients. Yes, if you have one MRD negative result, you may have 10 to 12% of the patients that may be PET positive. But if you have 2 or 3 years sustained MRD negativity, in our center, we have never had a PET scan positive.
Nice. Thank you, sir. So, but there is one question from Dr. Pankaj, which is still unanswered. I think that would be the last question that we take for the day. So, what factors decide induction therapy in your center currently with the availability of both VCD and VRD? How do you choose the VCD versus VRD? Pankaj, sir, you can take it on, please.
No, I think this question is answered because this was physician dependent and the policy of the institute at that particular time from VCD and then to VRD. But I have actually another question to ask, and that is, there are patients of myeloma who have predominantly bone disease, and there are patients of myeloma who sometimes they do not have any bone disease. So obviously, the PET positivity would depend on the load of the bone disease. So did you have the baseline PET CT scan in these patients, or do you think, what is in your opinion, that patients who have predominantly bone disease, what would happen to their PET CT scan post transplant or post maintenance?
In my opinion, patients who have predominantly bone disease are doing better than the other patients. And the vast majority of these patients, after autologous transplant, they make a PET-CT negative. So to me, the extensive bone disease is not a poor prognostic factor if, of course, they don't deteriorate the quality of life, meaning they don't create kyphosis that may predispose to infections. Otherwise, the extended bone disease with osteolytic lesions with no fractures, is not a poor prognosis. And we did a lot of studies. We had created a very extensive bone disease volume study with more than 20, 25 different parameters, number of lesions, dimensions of lesions, number of fracture in which bone, in the vertebral bone, in the long bones, if we had in the whole body low dose CT, diffuse infiltration in the femoral bones. So we had a lot of parameters in order to evaluate the bone volume, and we didn't find any correlation with survival compared to the patients who had extensive bone disease or median or moderate or low bone disease. There was no difference.
Okay, thank you. Thank you for the answer.
Thank you, sir. So,
is
with
one
this-
last question. Is it very difficult to convince a patient for regular bone marrow aspiration? Did you find any difficulty in convincing the patients?
Okay, yes, okay. Some of the patients don't want to have every 6 months, but immediately, when they didn't know exactly the value of MRD, they wanted to reassure that they were MRD negative. So we have not had such a problem. But I want to give you one new information, let's say. Dr. Kumar, Sajid Kumar, is preparing the new response criteria. So in the new response criteria, first of all, the MRD level is going to be the 10 to the -6. And second, is going to suggest to have the bone marrow aspiration either every 6 months or every year. I don't know exactly. But in between, he's going to suggest to have circulating tumor cells evaluation, plus minus M protein evaluation with mass spectrometry. So with the circulating tumor cells, I think you'll be in a position that after a while, probably after 2 to 5 years, will be in a position to substitute the bone marrow aspiration with the circulating tumor cells, at least for the response criteria.
Thank you very much, sir. Dr. Uday, now we can take over next session. Thank you, sir. Thank you. Wonderful discussion. And you have answered all the questions very patiently. Thank you once again. Dr. Uday? Dr. Uday?
Yeah, I think you can directly go to the quiz now.
This is also by, yeah.
Dr. Uday, are you there?
So, sir, thank you. Thanks a lot. I would request all of you to kindly scan this code and please use this code otherwise on slido.com. So either scan or you can get onto slido.com and put this. Now, from today onwards, we'll have the quiz open even for the faculty as well. So any faculty can also participate. So I request all faculty who are on board and all 150 people who are listening currently to kindly scan this code and take this forward. By the time you scan and you enter your name, we'll just quickly go on to the next part, that is the Eagle Eye competition. And I will not go into the process, which we have been explaining every time, but the winner for the Eagle Eye competition currently is Dr. Karan Sood, and he's an assistant professor from JNMC Wardha. So Nirav, you can quickly play this before we start our quiz. Nirav, can you play the recording?
A very warm good evening to one and all. I thank Image for this opportunity. Today we will be discussing about soluble B-cell maturation antigen levels for disease monitoring in oligosecretory and non-secretory relapsed multiple myeloma. Oligosecretory multiple myeloma is defined as serum protein less than 1 gram per deciliter, urine M protein less than 200 milligrams per 24 hours, or low free light chains. Non-secretory multiple myeloma has no measurable.
Nirav, can you increase the volume, please? We can't hear it.
And ratio.
So it is the same voice only.
Oligosecretory multiple myeloma in the relapsed refractory setting, and about 1 to 5% patients have non-secretory multiple myeloma in the de novo setting. There's a lack of biomarker in this setting, and soluble BCMA has shown to be a prognostic relevance in secretory disease post-BCMA, but the diagnostic value is limited. Here are a few mechanisms, one of which is post-treatment clonal evolution, and the other is evolutionary trajectory. The B-cell maturation antigen, the gene lies on chromosome number 16. It's a 20 kilodalton molecule and it's highly expressed on plasma cells. Gamma secretase cleaves the extracellular domain into soluble BCMA, and the half-life is about 1 to 2 hours. There are 3 domains to the BCMA. It's an extracellular domain where there is cysteine residues. There's a transmembrane domain, and there's an intracellular domain which activates the NF-κB, PI3K, and AKT. The aim of the study is to evaluate clinical utility of soluble BCMA as a surrogate biomarker of tumor burden and disease monitoring in multiple myeloma with focus on oligosecretory and non-secretory subtypes. Objectives are correlation analysis of baseline, longitudinal monitoring, and prognostic significance. So the methods are: sample collection was done using serum serially, stored at -40 degrees centigrade until analysis. Soluble BCMA levels were measured using enzyme-linked immunosorbent assay, and digital analysis was done using high-resolution ultra-fast scanner. Tumor volume was done using whole-body diffusion-weighted MRI, and CTCs were identified using multicolor flow cytometry. Results: 115 newly diagnosed multiple myeloma patients were retrospectively seen. No history of BCMA-targeted therapy was there. The median soluble BCMA levels was 8 times higher in multiple myeloma, with multiple myeloma patients had a median of 325 nanogram per ml compared to the healthy controls who had 41.4 nanogram per ml. Median soluble BCMA levels increased with increasing stage. There was a strong correlation with the percentage of bone marrow plasma cells and the total diffusion volume. Chromosome 1q had a significant impact on the soluble BCMA levels, as can be seen in 1q gain and 1q amplification. Soluble BCMA levels of more than 500 nanograms at diagnosis predicted poor survival. Here you can see a dot depicting a soluble BCMA levels according to the international stage, and as you can see, as the stage increases, the median of soluble BCMA also increases. Here you can see the high risk cytogenetics, where there is no difference in the soluble BCMA levels, but in the chromosome 1q21 abnormality, you can see in the gain and the amplification, the soluble BCMA levels rise. In this graph, the heat map shows that correlation between soluble BCMA and the laboratory parameters by heavy and light chain subtypes. correlation plot shows that the involved intact immunoglobulin levels correlated moderately with soluble BCMA levels in the IgG and IgA subtypes, and also in the involved free light chains in the light chain only disease. In the graph D, you can see a scatter plot of baseline soluble BCMA and the percentage BMPCs. In contrast to the M protein level, soluble BCMA levels correlated strongly with the BMPC percent. In this graph E, the TDV values with regression lines in blue and the corresponding 95% confidence interval in gray. Red and blue dots indicate high and low BMPC burden respectively. You can see a yellow zone with a low TDV and high soluble BCMA levels. This discrepancy could be due to under-extraction of voxels in the bone marrow with mild to moderate infiltration of tumor cells, because almost half of these patients were reported to have diffuse medullary lesions based on visual inspection of the whole body MRI by expert radiologist. In the graph F, you can see plots of soluble BCMA levels grouped by CTC burdens in log increase ranging from 0.01% to 1%. And as you can see, as the CTC percent increased, the soluble BCMA levels also increased. Multiple regression analysis was used and 3 factors came out to be significant, which were BMPCs, TDV, and CTC. The combined model yielded a more reliable prediction than standalone use of each factors with an adjusted R2 of 0.60. This is again shown in a 3-dimensional scatter plot with the x-axis showing percentage BMPCs, y-axis showing TDV, and the z-axis showing CTCs. And there is a scale which shows that all 3 values when high, the soluble BCMA level is also high. So till now, we've seen that more the number of plasma cells in the bone marrow, larger the tumor volume, more the CTCs, the higher level of BCMA in blood. Each factor contributes uniquely. The model explains 60.5% of variation in soluble BCMA levels, and this is more accurate than using a single factor alone. Beta-2 microglobulin did come out to be correlative, but had no predictive power. Soluble BCMA levels of more than 500 nanogram per ml at diagnosis showed a relapse which was faster and worse PFS, and it was independent of age, ISS, and high risk. On the basis of these findings, usefulness of soluble BCMA level for disease monitoring was assessed. The clinical characteristics and disease courses of 17 patients with oligosecretory and non-secretory multiple myeloma are seen. As you can see, the top 14 patients have secondary and the bottom 3 have primary oligosecretory, non-secretory multiple myeloma. In this swimmer plot, which shows relapse and treatment pattern of 17 patients, among the 14 secondary, that are the top 14, the median time to from diagnosis to oligosecretory non-secretory relapse was 51 months, and the median of 2 prior lines of treatment was there. In the image B, you can see a maximum intensity projection image from whole body MRI in the top 3 patients of OSR NSR with highest BCMA values. Especially the patient 15 had a history of femoral head replacement, which led to negative signal within the. So here you can see the longitudinal soluble BCMA kinetics in the oligosecretory, non-secretory, the secretory relapse, and the non-relapse group. And the median values were 348, 741, and 288 respectively. As you can see, there is a blue shaded area which indicates the range under the median of healthy controls. A thing to notice about the OSR and the NSR group is that exceptionally low level of soluble BCMA in patient 6 who had small solitary plasmacytoma in the sternum and minimal invasion of the BMPCs. Also, you can see that the OSR, NSR, MM before relapse events, that is 6 months before or at the time of most recent treatment change, revealed a significant elevation of soluble BCMA levels compared with those with the best response. In the panel below, you can see a similar change in the free light chain level. So in the figure I, you can see soluble BCMA concentrations at the time of OSR and NSR correlated strongly with the corresponding TDV values. In the figure J, you can see magnitude of correlation between the soluble BCMA and the BMPC's proportions at this time point was significant but modest compared to what it was at the time of diagnosis. Similarly, in K, you can see similar to newly diagnosed patients, OSR NSR patients with higher BCMA value, that is more than 100 nanogram per ml, had significantly poorer outcomes. So the strengths of the study is that it's a multimodal tumor burden assessment, robust correlation across different disease types, good methodology with high inter-observer agreement and multivariate modeling and clinical utility. The limitations of the study is small sample size, post-treatment confounding, no established BCMA thresholds, absence of longitudinal standardization, and heterogeneity challenges. So in the current context, it addresses the critical unmet need in MM. It shows that soluble BCMA enables early relapse detection, complementary to modern tools such as mass spec, AI imaging, and ctDNA. Also biomarker for MRD sparse disease such as oligosecretory or non-secretory. So in conclusion, it's a reliable surrogate, superior utility, non-measurable disease, predicts prognosis comparable to imaging and mass spectrometry, and integration with emerging tools is promising, such as AI imaging. Thank you.
Thank you. Thanks for that. I think, thank you, Karan, for presenting it. Nirav, can you allow me to share my screen? Yeah.
Yes, sir.
Just for the people who want to re-enter the code, please scan the code here. We request all faculty members and all participants to kindly enter the code. We have 16 participants till now, 18, 19. So the numbers are increasing, but we request you to quickly scan the code. Or you can also, if you are on a laptop, you can just put slido.com and you can put the gaming code 3538983. The reason for doing this is we want to have it at a very basic level And in fact, today the quiz master happens to be an MBBS student because we want the basics to be correct, but it's a KBC style, just not the right answer. We also want you to do it at the fastest finger first. So it does not matter whether you know it or not. It also matters how fast you click the answer. So we want you to do that way. So we have around 24 users till now. We'll wait for another 5 seconds before we shift on to the quiz. So let me introduce the today's quiz master. So we have Ms. Celine Rafael. She is going to be the quiz master for the day. She is going to take us through the quiz in this gaming mode. And I'll be handing over the stage to her. Okay, so with this, we'll start the quiz. So over to Dr. Celine.
A very good evening to one and all present here. We'll be starting the quiz now. Beginning with our first question. Imaging plus MRD negative as per IMWG criteria is MRD negativity defined by NGF or NGS along with, and these are your options. I hope everyone's logged in their answers. The correct option was all of the above. Leaders are as follows. We now move on to the next question. Which of the following is incorrect regarding the MRD negativity as per the IMWG criteria? Should meet the criteria of complete remission, absence of aberrant clonal plasma cells by next-gen flow cytometry, minimum sensitivity of 1, in 10 to the power 5 nucleated cells or higher, and it can be done in peripheral blood or bone marrow. Lock in your answers. And the right answer is that it can be done on peripheral blood and bone marrow. The leaders are as follows. Moving on to our next question. Sustained MRD negativity is defined as 2 MRD assessments with a minimal gap of 1 year, 2 years, 3 years, or 4 years. Lock in your answers.
Okay, as has been rightly brought out, the answer is 1 year. Though the article that we presented today spoke about 3 years, but as per the IMWG criteria, the correct answer is 1 year, whether by NGF, NGS, or by imaging, at a gap of 2 assessments, 1 year apart.
Next question. In the article discussed today, the TFR at 36 months post lenalidomide maintenance discontinuation was 50%, 60%, 75%, or 90%.
There is no negative marking, so people can definitely attempt.
Kindly lock in your answers. Right answer.
So the maximum number of people have answered it as 75%. So absolutely right. It is 75.9% TFR at 36 months post len maintenance.
And leaders are as follows. What is the best imaging technique to monitor MRD in patients while on maintenance? These are your options.
So as answered right by most of you, so it's the PET CT which is the best modality for monitoring MRD in patients on therapy.
Assays for soluble BCMA can be performed using techniques like
Okay, as has been rightly pointed out by 74% of you, all these techniques can be used for detecting the soluble BCMA.
a quick look at the leaderboard. Nivedita has been leading, followed by Abhinash Hota and Dr. Sanjeev. Moving on to the next question. BCMA stands for, very simple one, we have the answer. Right.
So as most of you have answered it right, it's B cell maturation antigen, and there's no change in the leaderboard. Going to the next question.
Anti-BCMA therapies are all of the following except ide-cel, cilta-cel, talquetamab, and teclistamab.
Okay, as has been rightly answered by 50% of you, it's talquetamab. By the way, ide-cel and cilta-cel are the first two BCMA anti-BCMA CAR-Ts available, and teclistamab also targets CD3 and BCMA together. It's a bite for that. So talquetamab is for the GPC-RD5D. So it's not the right answer. So it was all except. Oh, there has been a change in the leaderboard. Okay, last two questions, and people, you can actually still compete and try to win the race. So going to the next question.
Soluble BCMA can be used in clinical practice for monitoring disease activity, predicting relapse, assessing treatment, or as a predictive marker. The answer is all of the above. Baseline BCMA values more than blank is associated with significantly inferior prognosis. Lock your answers.
That brings us to the end of the quiz. And let's look at the right answer. So 52% of you have rightly answered it. It was more than 500 nanogram per ml. And this was also presented by Dr. Karan Sood in his presentation. So this is the level above which it is considered significantly having inferior prognosis. So with that, let's look at our leaderboard. So we have the winner, Dr. Abhinash Hota, who has answered 9 out of the 10 questions at a rapid speed of 2 minutes, 16 seconds. So congratulations, Dr. Abhinash, for winning the quiz. So with that, we come to the last part of the event. So I would like to thank all of our national and experts who are part of our team. And the topic for the next month's General Club is dexamethasone dose intensity. Does it have impact in the outcomes of the newly diagnosed multiple myeloma? So a secondary SWOG analysis, this would be discussed next month for the General Club. And also next month, we are not having any General Scan, but we have an interaction from one of our friendly nation, Sri Lanka, who will be presenting their experiences with multiple myeloma. So we will have that in lieu of the General Scan. And with this, I would come to the end of this particular session. So can I request General Nair and Dr. Pankaj sir to give final comments, please?
Thank you, Colonel Uday. That was very crisply done and very well done. And I must say that the article which was presented has so much of clinical application and practice. But these are the questions that always confront you, and you are challenged by it. And we are coming close to actually, launching maybe a bigger study in a randomized fashion to answer certain very pivotal question. So I thought it was a very, very important article, and I must thank Dr. Terpos for having actually being the first and the corresponding author for giving his valuable comments and the way forward. And I also would like to congratulate Dr. Sadashivdu for the way he actually discussed it with the various participants. And the eagle eye which was conducted was, I thought, again an eagle eye, because we are looking at replacements for the painful procedure called bone marrow, and obviously the role of plasma cells in circulation and soluble BCMA. How can we use these tools to actually make it more robust and less painful and maybe as effective in the days to come? But it was very well done. But though the volume was a little low, we couldn't hear all of it. The quiz, I must compliment, was conducted by a fifth termer from FMC, and I must congratulate her and also all the participants. And with that, I would request my colleague, Dr. Pankaj Malhotra, to say a few comments, please.
Thank you, sir. I actually enjoyed the session today, especially the quiz was new edition, and everybody could log in and see in real time what is happening, the answers.
Excellent.
As well as so it was excellent. I think we need to continue that. And thanks Uday as well as his team, as well as Sadashivdu and the other team members. Thank you.
So, sir, with the permission of the president and the past president, sir, can we close the session, please, for the day?
Surely.
Yes.
Thank you very much. Excellent.
Thank you, Sadashivdu, sir. Thanks to all executive committee members.
Thank you very much for.
So have a good day. Thank you, sir.
Thank you.
Thank you.